First, I'd like to express our warm and appreciative welcome to everyone. Today, we're presenting our product training session on how to revolutionize vascular recovery with VenoPlus, the second heart technology. We're going to go through our presentation and reserve questions for the afterwards. And at any time during the presentation, please feel free to submit questions through the Zoom chat. And Evan is going to collect those and just send a private message to the co-host, and we'll compile them. And we'll try to answer as many of these questions as possible at the conclusion of the presentation. And if we don't get to your question, please feel free to send it to me or any of our participants. Our first product training session focused on the applications of technology, and it was presented by Dr. Camarado. The second session we had last week was on the procedures for submitting the prescription and the process we go through, which was presented by Wendy. Today we're going to start addressing the major clinical gap left by passive therapies such as compression stockings and intermittent compression devices, which often fall short because of patient compliance or contradictions such as PAD. We're going to review how to position our active neuromuscular stimulator as a superior alternative that simultaneously increases arterial inflow and venous return. Then we're going to review specific high-impact call points for medical specialties, including vascular surgeons, podiatrists, family practitioners, endocrinologists, and cardiologists. After that, we're going to spend a little bit of time on some additional call points, which include the hospitals, the opportunity in hospitals for post-surgical use of the VenoPlus, and also the opportunity presented by home care providers. Afterwards, Dr. Camarado is going to again review the venous insufficiency and peripheral arterial disease applications, indications, and then we'll have the question and answer period. And as I said, again, any questions that don't get answered, please feel free to submit them, because I'm getting calls every day, and we want to make sure that everybody gets the questions answered and any other aids that we can have. We sent out with the package, I believe, about 8 comparisons and some other documentation. And we want to keep everybody as informed as possible. And our sincere thanks for everybody who's participating. And we hope this is going to be a valuable product training session. And we plan to continue this process probably once we get through the next couple of weeks, doing it at least twice a month. So with that, I'd like to introduce Dr. Camarado, and he's going to, again, present the technology. And Anthony, if you'd go ahead, I think we can get started here.
Well, thank you, Steffen, and welcome everyone. Good to have you. I'm going to make a couple introductory comments and maybe review just a little bit of the device and its application. And then we'll get into some very specific clinical trials, which are quite impressive in their results. The VenoPlus is a neuromuscular electrical stimulation device. It's engineered with second heart technology, as Steffen mentioned, and we can get into that in the discussion period. The VenoPlus activates the calf muscles directly to reverse muscular atrophy in those patients who have muscular atrophy. It increases blood flow, it reduces edema, and it alleviates pain in the lower extremities. The VenoPlus is a small, very easy to use, pocket-sized device. It triggers calf muscle contractions improving muscle function, and it improves the local hemodynamics when it's in use. Traditional venous compression therapies rely on external mechanical pressure, and that's important to understand, external mechanical compression. So when the EPC devices contract, it squeezes all of the soft tissue from the skin to the bone, which includes the blood vessels. So traditional venous compression therapies rely on this external mechanical pressure, as I mentioned. And these are compression stockings or pneumatic compression pumps, and these are referred to as passive therapy. These are passive therapies. The Venopus electrical impulses directly activate the calf muscle, causing controlled active contraction similar to the ambulatory physiology. So this is where the second heart technology comes into play. Unlike pneumatic compression devices that apply indirect external pressure to the limb, the Venopus produces direct internal compression through muscle contraction. Dr. Andrew Nicolaides, who is a highly regarded vascular surgeon and clinical researcher from the United Kingdom, took time to study the Venopus device in volunteers in his vascular laboratory. And what they found was that when the Venopus contracted, the peak systolic velocity in the popliteal vein increased by tenfold in the popliteal vein compared to baseline, and the total volume flow in the popliteal vein was 12 times the baseline value. So if you think about it, blood involved in these hemodynamics will be very unlikely to clot. So it's unlikely to clot. Maybe we can use it to study the impact of these venous hemodynamics. And this was studied by Zolotukhin and colleagues, published in the Journal of Phlebology. Now, they performed a study in high-risk surgical patients, 80 high-risk surgical patients. And they did a prospective controlled study. They gave the Venopus to 40 patients, and they had a control group, which was the other 40 patients. And they studied these high-risk patients, and the ones that received the Venopus, they used the device for 100 minutes per day or more. And then when they looked at the incidence of post-op deep venous thrombosis, it was 25% in the control group and 2.5% in the Venopus group. That is a reduction of 90% of post-op DVT in the patients who received the Venopus device compared to the control group. Now, not only was there a significant reduction in DVT risk, there was no evidence at all that pulmonary embolism occurred. So there did not appear to be any increased risk of PE. Now, looking at another application for venous diseases is the treatment of venous insufficiency and the treatment of edema in these patients who have markedly compromised ambulatory activity. And they studied chronic painful evening edema, and they looked at the reduction in evening leg circumference, and there was a significant reduction in evening leg circumference, significant reduction in pain scales in the patients treated with the VenoPlus, and the heavy leg sensation disappeared. And these were all highly significant observations. And they also documented the durability of the edema reduction. So here you have acute DVT being prevented. You have chronic venous disease, probably lymphedema compounded on top of chronic venous disease with very good clinical results. And then if we look at our patients with peripheral arterial disease and how this device can impact those patients, there was a study published by Abraham in the Journal of Vascular Surgery, where they took patients with chronic intermittent claudication and type 2 diabetes. And then they randomized patients to receive the VenoPlus or not. And they found that there was a 41% improvement in the absolute claudication distance in the patients who were treated with the VenoPlus device compared to controls. And that was with the use of the VenoPlus for 1 hour a day. My impression and my opinion would be if we were to treat the patients with the VenoPlus for 3 hours or 4 hours a day, that we would see even greater improvement in walking distance and greater improvement in the quality of life. So this covers many of the common problems that can be treated on the vascular tree. Obviously, patients with vascular disease will see vascular surgeons, but they'll also see cardiologists, radiologists, and when you get to foot-specific diseases, podiatry. So, Steffen, maybe I'll turn it over to you or whoever's going to pick up on the other topics.
Sure, Anthony. I got a couple comments. If you could just tilt your camera a little bit, we like to see more of your face. Okay. All right.
I have a question. Yeah, so Dr. Camarado, so we call the VenoPlus with second heart technology. Can you talk about what the second heart is and why it's so important?
Sure. The second heart technology basically was designed to mimic walking. And what happens to the musculature in the lower extremity when a patient walks? Well, the muscles contract, but the soft tissue is not squeezed. The soft tissue meaning the skin, the subcutaneous tissue, and the soft tissues comprising the blood vessels, arteries, and veins. And when you look at the intermittent pneumatic compression devices, they squeeze all of the tissues from the skin to the bone equally. But if you take that same patient and walk the patient, only the calf muscles contract, but the soft tissues are not squeezed. And that has a appreciable advantage to the patients because you're emptying the compartment that the calf muscle is in. You're emptying it from blood and stagnant blood in the leg, but it's not being the leg is not compressed in total, and there's advantages to that.
And the calf is clinically called the second heart, correct? So there's the tie-in.
Yes.
Thank you.
Thank you, Anthony. I think the next area that we were going to cover, we're going to talk about specific call points. And what we're going to do is we're going to have Anthony, Taft, Blake, and Wendy cover their experiences and what they're seeing because we're trying to wrap everything together so that if you're calling on a certain call point, whether it's an endocrinologist or vascular surgeon, podiatrist, we can have the solution specific to their patient's issues. Maybe Anthony, you take just a minute more. I hate to ask you, but we talked about it. The vascular surgeons, when you see a patient, what would you look at for prescribing the VenaPlus? How would you look at that type of patient?
Well, compression technology is very valuable in a wide range of vascular diseases. And as you see from the studies that I've quoted, what specifically was your question, Steffen?
I think the question was when a sales rep, independent sales rep approaches a vascular surgeon, how would you suggest, this is, and I didn't prepare you for this one beforehand, but what would you want him to tell you about the VenaPlus? In other words, compare it with the compression, which I think you did very, very thoroughly before, but just a quick recap on that.
Two major issues: effectiveness of the device, which is highly effective. So your sales rep has the data, or will have the data, underscoring effectiveness, and ease of use. This is so easy and comfortable, and the patient can maintain their activities of daily life, which you cannot do. You're completely confined to a bed or a chair with the external pneumatic compression devices, but you're fully ambulatory and fully functional with the VenaPlus.
And Dr. Camarado, this is Blake question. Do you think you could use this in together with some compression? Would you use it in I almost think it should be a complementary type sale versus hey, stop using compression, use our device. What are your thoughts?
Well, if you're speaking specifically about compression stockings, anybody that has compression stockings prescribed for edema, they should have the VenaPlus, because you will notice a significant reduction in edema and a significant reduction in discomfort. So there's a very real place, and as an adjunct to a compression stocking, I think it's ideal.
Well, quickly, one thing we've found is that VenaPlus used in conjunction with compression stockings, as Dr. Camarado said, really increases the compliance with compression stockings. In fact, doctors have been able to lower the pressure in the compression stockings if they've used them in conjunction with. So it's a really good point to use them in conjunction with each other.
Yes, thank you.
Yeah, that's a good point.
Ted, maybe you and Blake, I know you've got a pressing commitment that you have to go to. Maybe you can just discuss the podiatrist. You call on them on a regular basis, and if you would tell everyone, kind of share your thoughts and the best way to approach a podiatrist.
Yeah, and I've got like 3 minutes, so because of another commitment. But yeah, so with podiatrists, now what you have to be cognizant of is the scope of practice in the state in which you're calling on these podiatrists. For example, in Georgia, you can call on, their scope of practice is from the soft tissue from the hip down. So they can actually treat, a quote unquote, treat venous insufficiency, not from a surgical standpoint, but from a maintenance standpoint. So just be cognizant of that, first of all, the scope of practice. The other side of that is if I go next door to Alabama, their scope of practice is from the ankle down. So they're more than likely not going to utilize this product. So then you would probably want to concentrate more on the vascular surgeons. But podiatrists in general, as long as their scope of practice is okay, they see venous insufficiency all day long. I mean, all day long. All these patients. I mean, it's probably a quarter of their patients, if not a third of their patients, have venous insufficiency, and it's just a great adjunct therapy. Venoplasty is just a great adjunct therapy to utilize in their clinic. You may get asked about them being able to utilize their DME, and it's not favorable. The way it's reimbursed right now, it's not favorable for that, but that's something we're working on. So you really want to find the podiatrists who are more patient centric, so to speak. And some examples of that would be, podiatrists who are actually prescribing like wound vacs. They're not making any money on wound vacs. The tactile pumps, they're not making any money on the tactile pumps. So if you can find those podiatrists who are more patient centric and they are prescribing those type products, they're going to be more apt to prescribe Vena Plus. But the thing that they're going to be very impressed with is the portability of the unit, and also which is going to increase patient compliance. We can't directly discuss wound care, but podiatrists see wounds all day long. And if the patients have venous insufficiency, a lot of times they're going to end up having wounds that are going to pop up or pop out, however you want to say it. And those are going to be venous leg ulcers, or they can end up having diabetic foot ulcers as well. Not necessarily from the venous insufficiency, but they will have diabetic foot ulcers. But if the patient has edema and they have those two types of ulcers, they will see positive results in their wounds. We can't discuss that, but they'll see it. And they'll understand the fact that those wounds are not healing very well because a lot of these diabetics are metabolically deprived and their circulation is very poor. So it's a great call point. I've had some good success with several podiatrists utilizing the product, and it's just a fantastic call point. And really what I just said applies primarily to the commercial podiatrists, but if you get into the VAs, they're a little more lenient on their scope of practice. And so if you can get into a podiatry clinic within the VA, you can probably make hay with this product. A lot of times in the VAs, the podiatrists are the last stop before they get sent to vascular. No disrespect, Dr. Camarada, but the podiatrists really try to get those wounds healed the best they can, because generally in the VAs, once they get to vascular, there's going to be an amputation. I did wound care consulting in the VA for 10 years, and I saw this. And so it's really, the podiatrists love to be able to get these wounds healed, so they don't get sent down to the amputated. So again, we can't discuss wound care, but we can discuss circulation. And these podiatrists know that by increasing circulation, especially in these metabolically deprived patients, they're going to see improvements in wound healing. So that's about what I've got to say, and then I've got to jump off. But if anybody has any questions about podiatry, I've got like another minute or so if anybody has any questions.
I thought you did a great explanation of the podiatry market. I really like Wendy's explanation of the second heart technology and how that relates to the podiatry market because of the, treating the foot. And one of the questions I always ask any surgeon or any podiatrist that I call on with Vena Plus is, do you have patients that you wish would walk more? And the answer is almost yes for all these patients. We all wish that, as a provider, we all, I'm sure, would wish that these patients would walk more. And when you wear the Vena Plus for an hour, it's equivalent to how many steps, Steffen? 3,600?
3,600. And
Yeah.
I think your question is a fantastic question. It's a good question, because the obvious answer is yes. And that's where the Vena Plus fits in so well. Blake, I know you call on podiatrists, and maybe in addition to Taft's comments, if you have any supplementary comments, that would be great.
Yeah, the only thing I would share is that, and again, Taft did a great job of describing how we would present this for, say, some of these wound patients, because VenoPlus brings that vascular supply to anything's going to heal better when you have that blood supply, and this product really brings that blood supply to the treatment area. I've had really good success down in Colorado Springs with a few of the podiatry groups that I work with, and talking about just that vascularization of the lower limb and the reperfusion of the blood. So that kind of falls into a lot of different treatments that they're doing either for wound care or other things as a podiatrist. But the other market that we talked about a little bit is this mobile wound care market. There's a lot of patients out there that are immobile, not mobile. And there's a big market for that as well. It's getting loud here, so I'm going to shut off my mute. But that's kind of the success that I've had in the last few.
A quick add to that, like there was a study done a few years ago, not that long ago, at the University of Arizona. It's called the LU. That's one of the ones that we've circulated, and there we were able to show that they restored the circulation in a diabetic foot. And I asked Dr. Sawinski about it, and I said, was that your expectation? He said, yes. It's basically angiogenesis, propagation of blood vessels around the dead blood vessels. And it's not an indication for use, but that study is available. And I think if you don't have a copy, I think we sent one to everybody. It's worth looking at. I think the next area we're going to go into, and I'm going to ask Wendy if she would talk about her experience with the family practitioners and also endocrinologists.
Terrific. Thank you, Steffen. Thanks, Blake. Thanks, Taft. So a couple questions. So everybody, if anyone's on their computer, who has a primary care doctor? Raise your hand or hit your thumbs up in Zoom. Does everybody have a primary care doctor?
Yes.
Yes. Great. Guess how many they are in the United States? Look at those thumbs up. Thank you so much. Thanks, Jahan. Thanks, Mark. Appreciate the participation there. It's 200 to 220,000 active outpatient primary care physicians in the United States. All right. What vascular surgeons are 1/50th of that. Endocrinology is 1/25th of that. Podiatry is 1/12th of that. Okay, so we're going to focus on primary care, podiatry, and endocrinology. So everybody has a primary care physician, and all those patients that would benefit from VenoPlus also have a primary care physician. My talk track into these primary care physicians, and probably the most orders I get is from a primary care doctor, a family doctor, is reminding them that they are the first line of defense from having to refer their patients either over to a specialist, and then that leads to X, Y, and Z. Now, the thing that I do when I'm in these clinics, and a lot of you might get the opportunities where you do doctor details. I call it loitering in the halls. You either get back there to set time to talk to the doctors in between patients, or you just sneak back there and you get a chance to talk to them. Is you want to help them visually connect. I see a patient, I see these things. This patient becomes a candidate for VenoPlus. So I've gone as far as creating a slide when I'm standing there and the doctor walks up, and it's of a person walking with an assisted walking device. And it's a person that's using compression stockings. So I want them to understand whether they prescribed those devices, the compression stockings, that those patients more than likely are a candidate and would benefit from using VenoPlus. They love it when you say things like, do you remember from medical school that the calf muscle is considered the second heart? Oh, yeah. Well, this is VenoPlus with second heart technology, and you can go right into it. And I think, Dr. Camarado, I think we need to probably bullet point some of those comments that you made about why this is different from using compression stockings, why this is different from a pneumatic pump as well. All of those things so that you're differentiating against that. So primary care, I think, is a huge opportunity for all of us. The other specialty that I've had a lot of success with is endocrinology, all right? So particularly, I live in San Antonio, Texas, people. Today is the first day of Fiesta down here, and there is a ton of diabetes. One of the largest endocrinology clinics in North America is based here in San Antonio. So endocrinologists are actually a chronic disease gatekeeper. So they're that next that you get referred by your PCP. And a lot of the PCPs, by the way, are managing diabetes until it gets beyond what they want to manage. And then they get that referral to the endocrinologist. But the diabetic doctors are the ones that are seeing the diabetic ulcers, the neuropathy pain, restless leg syndrome, etc. And a lot of them also have specialty testing that they use. So I really encourage you, in all of the call points that you go on, try to find out what tests they run. What kind of tests are they running? Are they doing an ABI testing? That's different than I put my fingers on your wrist and I put my fingers on your ankle to see if your blood pressure is the same, right? Find out what they're running so that you can go in there and potentially utilize the results from that test to talk to the doctors about when they should recommend VenoPlus. One of my endocrinology clinics uses a device called TMS. It does pseudomotor testing. It tests the micro and the macro vessels, etc. So when I'm in talking to all the providers, including the nurse practitioners, I say things like, hey, when you see that this patient has even gone and been referred to TMS testing, and you review that testing and you see X, Y, or Z, that's a candidate for VenoPlus. All right, so I'm going to stop there and see if there's any comments or questions from all of you great sellers. So here's what I recommend you do. If you have not at least gone out into the field and just started to approach whatever specialty, whatever call point you think I understand, or you have relationships, go out, make 5 to 10 calls and see how these providers respond. See what questions they may have that you're not going to be able to answer all of them, but that's how we learn. And of course, we all know that it's a great reason to go back in and say, hey, I need to go see Dr. Akras because he asked me a question last week and he wanted me to get the answer to him. Can I get back there for a few minutes while he's in clinic? So it gives you that reason to go back in. Go out there and apply some of these points that we've talked about. We'll do it. I think what we need to do, Steffen, is get some of those specific details, just bullet points that Dr. Camarado called out, that people can have as a cheat sheet until they memorize what they want to say in front of a doctor. And then you're going to customize it. You're going to make it personal to what you're comfortable with saying. If you have a relationship with a doctor or not, how you understand how they like to receive information. Are they a white paper person? Do they want one slide? Do you get 60 seconds? And you'll know how to tweak what your messaging is to all of these providers. I think that's it.
I think that's it. You made some great points, Wendy, as you always do. And I actually did send out a cheat sheet a couple hours ago. Okay. Take a look at it. I'm looking for it right now myself, but I think the bullet points, the points that Dr. Camarado made are outstanding, and we will put together expand that cheat sheet. I hate to call it cheat sheet; it's really an informational sheet. But I think the points that you made in approaching the primary care physician and the endocrinologist, excellent. I think we're going to move on here. There's a couple of other opportunities that I want to just touch briefly on, and these are the hospital post-surgical discharge. One of Anthony's comments some time ago was, when you go into that setting, we treat, and I think that you'll have to correct me, Anthony, I could be misquoting you, but I think you said VenoPlus treats post-surgical thrombotic events. In other words, DVT and everything. And right now, we have a couple of groups that are looking at, they're calling in the hospital setting as part of the discharge package for post-surgical treatment, whether it's orthopedic surgery or other surgeries where the possibility of DVT is present, which is a very, very large number. And the nice thing about that is that from our standpoint, it's a direct sale to the hospital, and the hospital includes it as part of their discharge package. And I'm not, we're going along here pretty good. I want to have time for questions. The other area, and we're going to investigate it more, is the home care providers. When we first started looking at this technology a few years ago, and I've related it to everybody in our team here, we went down, there's a group called Prairie River Home Care. Now they're called Adara. In Minnesota, there's two large home care groups. One is Adara and the other is LifeSpark. We went down to their Rochester clinic and their facility there. They work with the Mayo Clinic, the VA, and we had a number of patients, both from that were working with the hospitals or the Mayo Clinic as well as the VA, and had some excellent results. And one of the things that I think everybody, if they're not aware of it, they should be, is that the home care providers earn bonuses from Medicare or the commercial insurance carriers if they exceed the expected outcomes. So from that standpoint, there's a financial reward as well as, more importantly, the treatment of the patients that are under home care. And typically, I think the demographic for the home care patients is going to be a very good fit with the patients who could use our Vano Plus. So we're going to look and develop marketing materials specific to those two potential markets. And I think as we go along, we'll discover additional markets. But those, I think, are two that offer a great opportunity. I think, just to recap, I think Dr. Camarado really reiterated the value of the Vano Plus technology. In comparing it, doesn't mean that the other technologies are bad. It just means that ours is, in many cases, more applicable and more effective with relate to treating venous insufficiency and peripheral arterial disease because of the increased blood flow. And I think now what we'd like to do, and Evan, I think, have there been some questions coming in that we can address?
Hi, Steffen. No, not currently any questions in the chat.
Okay. Well, then why don't we open it up for questions from all the participants here?
Hey, Steffen, Don Smith. Hey, so you mentioned about using this thing in place of compression stockings for post-surgical patients. Do we have any data for that?
We do have some comparisons, but I think the question, I think the real answer is to use it as an adjunct therapy or in use with compression stockings. I think Dr. Camarada addressed that, and I think that Wendy touched on that as well. I think one, you have it, and Vin mentioned it too, the doctors, and Vin, maybe you want to just reiterate the feedback that you've got.
I've been talking to Dawn. I've been talking to quite a few patients lately who are actually putting on the Vano Plus on their legs, putting the compression stockings over them, obviously with the pigtails hanging out and using them that way. I can't stress that enough. The doctors are really impressed when you talk to them about the compliance and how this helps. It's a big problem, as everybody on the call probably knows. Patients do not wear, Dr. Camarada can probably talk, patients lie to their doctors, and they do not wear their compression stockings the way they're supposed to do. They're hard to put on, they're painful, they're hard to keep on, and this really helps them comply. And can't stress that enough. So, but that's one of the ways I'm finding patients are using it. And I think Dr. Camarada, we've talked about it. It's perfectly okay if they put them on and put the pads on and the compression stockings over the pads and use it that way.
Yes, it's very acceptable. The compression stockings are very difficult for patients to get on and take off. And they generally need someone else to help them. They can't do it themselves. And when you get adequate compression, many of these patients do not have hand strength, and you need hand strength to get them over the ankle, get those stockings over the ankle and up the calf.
Plus, physiologically, right, Dr. Camarado, they don't
So
do
it
the
may,
same things.
they don't, it may end up being that you're going to replace the stockings with the Veno Plus. And I can see that happening in actually the majority of patients.
It's a $3 billion market, by the way, the compression stockings. And if you go to any of these meetings, a lot of compression stocking manufacturers that are exhibiting. I think the other thing is that Vin touched on what we're doing now, just to bring everybody up to date. We are contacting every patient after they receive the Veno Plus, a day or two afterwards, to make sure that they know how to use it. We have a checklist that we're going through, and we're keeping track of that. Now, we're going to have Kuro work with us to follow up on that, but we're going to, just because of compliance, and it's amazing. A lot of people don't read the instruction manuals. But anyhow, we started doing this. Ben started contacting them, and one, to get hold of them sometimes is a bit of an issue because people don't answer the phone. But the bottom line is that they're going to be trained on how to use the technology. We're going to follow up at the end of 1 month to make sure they're still using it, don't have any issues, and they have a contact number with the customer service if they have any issues on how to use it. So I think it's very important. One of Taft's doctors was asking us on the follow-up, and that's how we're following up with the patients. So I think that the question about the compression stockings is an excellent one.
Can I make a recommendation on that same subject, Steffen?
Sure.
I ask doctors this all the time. Do you recommend to patients that they wear compression stockings? Oh yeah, all the time. Great. If you prescribe Veno Plus, the benefits they would get over compression stockings is X. And there's one slide that's in the presentation, the slide deck, that shows here's what a compression stocking does versus what Veno Plus does. So you get them thinking about compression stockings, this is better. And I think you'll have a lot of success there.
Can I ask one more question about neuropathy? So I had it was an orthopedic surgeon asked me, because he has neuropathy himself. He's like, so if I use this device, and it feels good, can I use it for longer than an hour on? And does any resistance built up to it? We have to use it for longer periods of time to get the same effect? I told him, I don't know. I'll find out for you.
I tell my patients you cannot overuse this device. The more you use it, the better it's going to get. So you cannot overuse the device. So for those seniors where we do have a very, very high compliance, as we've talked about, they sit down, they start with Jeopardy, they turn the device on, it shuts off after an hour, they're still sitting there, turn it back on.
Anthony, I think
that's what I would recommend. Yes.
I'm sorry. Go ahead, Anthony.
No, I would recommend the same thing. Yes. The 1 hour time slot I believe is just arbitrary. You'll see a lot of differences in the duration of compression with the Veno Plus, and it makes sense that if the patient is comfortable, and we want them to be comfortable during compression, if the patients are comfortable, there's no reason to discontinue therapy.
How long? So if somebody has neuropathy and they haven't done anything else before, what's the average time that people start to feel something? Like, my legs aren't numb anymore. I can walk around. If I use this 2 or 3 times a day, what's the average length of time that people start to get some therapeutic benefit? Are they feel that they're getting some benefits? Anybody have any idea about that?
Well, the neuropathic extremity is, there's such a wide range of feelings. I mean, some neuropathy is painful, some of it they just don't have any feeling at all, and everything in between. So it's a difficult question to answer, Don, because I don't think there is a definitive answer.
So basically, just tell them to keep using it a week, 2 weeks, a month.
Well, if they
Um,
start,
and they should.
if they start out with a swollen extremity, you have a different type of discomfort with the swollen extremity, and if you get rid of the swelling, they may notice that they're much more comfortable, and obviously that's a good sign.
Gotcha. What if it's
Don,
just like straight neuropathy where patients, for whatever reason, they may not be diabetic, but they have neuropathy in their lower legs from circulation, et cetera, and they don't have any edema. Are they still going to see some decent relief for that for the most part?
I haven't seen any studies along those lines, Don, so I'm sorry I can't address that.
Don, this is Vinny. I
Thank
can
you.
give you some anecdotal evidence. Unfortunately, at the moment, I am from a drug that I'm currently taking. I have a drug-induced neuropathy going on, temporary, hopefully. So I use it, 3, 4 times a day, early in the morning, in the evening, and if I have time during the day, I use it. And what is going on is my feet are completely numb, and I can't really bend my toes and wiggle my toes. Literally within minutes, I have to be honest, of using the Vanoplus, I can start wiggling my toes again. And and then as the day goes on, it'll get worse again. And then I use it again and it gets better. So I have no proof that it's going to cure it, but I do know that when I use it, the symptoms tend to go away or at least make it much more comfortable. So
Good to know.
I don't know if that helps you. I don't really have any more. And it's only been several months that I've been doing this. And hopefully when I'm off this drug, I don't have to do it any longer, but I hope that helps a little bit.
No, it
And
does.
I
It
think,
absolutely does. I mean, these people are just looking for some kind of relief. And I don't have it, so I can imagine what they're going through. So if they can get any kind of relief at all, I'm sure they'd be happy. Thank you.
Don, I can give a similar anecdotal. A very dear friend of mine, she's passed away now, but she'd been treated for cancer for probably 15 years. And apparently the cancer medication she was taking caused neuropathy. So she told me that when she was trying to walk around, it was like walking on shards of glass. That's how painful it was. And she couldn't drive or do any of these things. She did use the Veno Plus, and she did get pain relief. I don't know that there was any other impact. The pain relief was very important to her because it enabled her to walk around in the house and so on and do things that she was not able to before. So that, and again, the anecdotal stuff, we got all kinds of anecdotal issues. We have one individual, and I'll just mention this briefly. He's also passed away, but he was he had been the VP of compliance for Pfizer, and he wrote a very, very, very concise. He had gone to Columbia Medical School in New York. He was a claudicant. He could only walk a half a block. He had to sit down. He used the Vano Plus, and I think we've referenced it. We do have studies on that he was able to walk around. There's a little community called Wayzata in Minnesota, which is a little bit like Rodeo Drive and so on, that type of community. So he was able to walk up and down the street and even do work in his yard after using the Vano Plus. And he wrote a very, very nice testimonial, and I don't think there'd be any problem with sharing it. He's very, very, very precise and very clinical, I guess, in his presentation. So I think there's a lot of applications that when we start looking at it, even though the increased blood flow in his case, apparently, and the I think microperfusion of oxygen had a big impact on his the impact on as a claudicant. So,
Yeah,
but I think
great info. Thank you.
I think again, we got to be careful because I think if Carl Stamp was here, he'd be, we can't, just like we said, we're frustrating. You can't talk about certain things, And yet, the doctors will understand increased blood flow and the oxygen flow and all of these things, the benefit. So I think, again, if anybody has any questions that you can think of after we're finished, I'd encourage you to send them in because I think that's part of the process we're involved in now is establishing the best ways to approach the market and the market opportunities. Just from a business standpoint, we are developing a business model that makes sense for the VenoPlus. And it's really a remarkable technology. I think we all know that. A lot of us are using it regularly.
Steffen,
Johan, question?
yeah, I had a quick question. I was wondering about like the patients that undergo like a balloon angioplasty or like a rotational thrombectomy to leave that patency open long term after the procedure. Are there any data to support that?
I'm sorry, could you repeat that for
Yeah.
for me and for everyone?
Yeah, so for patients that undergo like a balloon angioplasty or they do like a rotational thrombectomy to increase like that first or second degree patency of the vein, is there any data to kind of like support that for those patients? Do you feel like that's like a appropriate call point?
There are some data, and I need to be cautious on how I phrase this. There are some data analyzing external pneumatic compression. Now it's not the VenoPlus, but external pneumatic compression in patients who have had bypasses in their lower extremity, and you can actually with the external pneumatic compression, you can actually record increases in the flow through the graft as a result of EPC. My suspicion is that if you were to use the VenoPlus, you would see at least the same improvement, if not more. But again, we need to be quite cautious in our statements regarding that.
Okay. What about for like dialysis centers?
That's a good question, and I don't know. I haven't seen any data on dialysis patients.
Sure. Conceptually, I can see how it would make a lot of sense.
Yes, sure.
Thank you.
This is Mike Hughes. I have one question. Are there any studies showing that use of VenoPlus you can reduce a patient's Lasix or Eliquis?
No, the mechanism of action is quite different between those drugs and obviously the VenoPlus. So I think the studies would have to be very rigorous before we would find an answer to that question.
I can give you an anecdotal comment. One of the bases, and Anthony, I don't know if you've talked to Dr. Sawinski on this, but one of the reasons he developed this technology was he has Leiden factor 5. And at the time, Joseph was really one of the fathers of neuromuscular electrical stimulation technology. And he was a professor at both Harvard Medical School and MIT in their PhD program in electrical engineering for medical devices, and has about 35 patents in the pacemaker and other related areas. But he was taking warfarin, and one of the side effects of the anticoagulants is bleeding. So he wanted to reduce his, and this is again, it's not anything clinical, it's just anecdotal. He and Dr. Nicolaitis, who Dr. Camarado spoke of before, that's when they started looking at turning neuromuscular electrical stimulation technology into a vascular product. And that's was the first study that was done was at the Imperial College of Medicine. But that was the basis for this product, a vascular product, the origins. So, if there
Steffen, can I
aren't
make a
any-
comment
Thank you.
to the questions about, calling on specialties that we haven't talked about? Walk in. I just start talking to the doctor. I went to a medical building. I was like, oh, there's a pulmonology doctor. How would this apply? And I got back to talk to the doctor, and he goes, oh yeah. I was like, that was easy. So don't be afraid to walk in and talk about the device, what it does, how it works, and let the doctor come up with the use case for you.
Wendy, I think you focused on a very important point. That is that not all doctors are aware of the Vano Plus technology, the electrical, deep stimulation. And in fact, I'd venture to say Dr. Camarada can probably be a lot more precise on this than I am, but it's surprising how many doctors are not aware of this technology at this point in time. So it's almost it's a bit of a missionary position too, because they think of, some people get confused with TENS units, which totally different. There's basically blocking of signal as an analgesic, or the neuromuscular electrical stimulation devices, which are primarily designed for muscle rehabilitation. So I think the awareness is something that we also have an opportunity to really work on. It is in many respects a new technology for many doctors. Well, we've gone exactly 1 hour, I think, and we'll one of the thoughts, and I welcome any thoughts. We're looking at having I think Wendy suggested a next training session on the VA. And we have a company that we're working with that does the billing for us with the VA. And you heard a little bit from Andy and Maggie Dietrich last week. And I think we have a program probably focused on the VA and what we have to do to get in. And that would be, I think, something of interest to everybody. Wendy, do you have any comments on that?
No, I think that's a great next step, particularly if you've got relationships there already. And if we have not shared that flyer, it is put together so well. It covers all of the main points for you to call into the VA. If you need help with credentialing and you don't understand what that means, we can talk through that as well for those that maybe have not called into the VA previously.
It's just to give you the numbers, there's about almost 10 million patients that are using the VA regularly. And again, the demographics are there, and also the underlying chronic conditions. So it I think offers a real opportunity, just like Taft had mentioned earlier on calling on some of the podiatrists. And I think they're very patient oriented as well. So I think,
quick comment on the VA, and to compound what Wendy said, we have that 1-page document Steffen sent everybody, and we have the FSS contract, and it's really nice as a salesperson to go into a place, and that's a license to hunt, meaning we have a contract. Can't always walk into a hospital, and if you're calling on a hospital and you don't have a group contract, it's the first question they ask you. So when you go into a VA, we do have the license to hunt. So it's a big advantage and pretty important. I would really try to concentrate on them.
well, again, in closing, I'd like to thank everybody for participating today. If any questions come up afterward, please send them in and we'll answer them as well as we can. And with that, thank you. And if any other closing comments, otherwise, I think we've had a good session.
Thank you. Thanks, Dr.